Everybody, I'm Justine Hadcroft. I'm a respiratory consultant. I work at the Royal and I work with the Liverpool Community Respiratory Team. I'm going to do a short presentation about X-rays, and you'll be happy to know there's no reading required, just looking at pictures. So it's kind of representative chest X-rays, and I'll just talk through what I see when I'm going through. And if you want to join in, I'll probably ask some questions and ask people for opinions about what they think might be going on. So I'll start by sharing my screen and then we can make a start. Okay. So yeah, chest X-rays, and that's me, Justine Hadcroft. So we've got two lungs, which is really handy because it allows you on a chest X-ray and when you're doing clinical examination as well to compare one side with the other. And that helps you decide if there's abnormalities or not. Generally, on a chest X-ray or a scan, anything that's got air in it will look black, and anything that's got liquid or solid in will look white, and anything that's a mixture of the two will look a bit greyish. So the whiter, the more dense the structure you're looking at, and the blacker, the more aerated the structure. So this is just a normal chest X-ray, and you can see a lot of things on a normal chest X-ray. You usually have the name of the patient, so it's always really important to have a look and make sure that the X-ray that you're looking at belongs to the person that you think it does, and that's usually kind of the top right hand corner. So just make sure it's the right person and date of birth. And when you're looking at chest X-rays, you can either do it methodically, kind of having a little checklist of various bits and pieces that you want to look at, or you can go straight for the obvious abnormality. It doesn't really matter which, but I think what you need to do is make sure that you do have a system for looking at everything, because if there's an obvious abnormality, you might miss more subtle stuff as well. So on this chest X-ray, these are the lungs here, these kind of black things full of air. Left lung here, right lung here. The stripes are the ribs. This is the heart. You can see the right ventricle here, the left ventricle there. Diaphragm, right side, left side, and anything below that is abdominal. We don't need to bother about that in respiratory usually. We've got the clavicles here, the scapulae, the humerus, and can you see these little kind of these little things in the middle there? There are vertebrae, and then these are these little things that stick out, the spinous processes. So they actually look like they're at the front, but they're actually at the back of the neck. So somebody's not
okay, you mean
muted.
she just muted? Oh no. All right. Oh.
Okay, right here. So when we're having a look, we want to see that.
I think you've gone muted, sorry. It's still muted for me anyway.
Justine, you're muted.
Sorry, Justine, yeah, we can't hear you.
Can't hear you. Still muted, Justine.
Am I muted still now or not? Still, okay.
I could hear you before, just now. I could hear you there.
Yes, I can hear you now.
You can hear me now?
Yeah. All
right, okay, right here. I think I tried to mute somebody else and managed to mute myself then. Right, okay, we'll go back. We'll go back to here then. Whoops, go back to here then. Right, so how far did you hear? So we were looking at the vertebral column and the spinous processes, and the lungs should fill the whole of the hemithorax on the right side and the left side. So you shouldn't see any difference in uniformity at the edges or the middle here. When you look at the junction between the ribs and the diaphragm, we call that the costophrenic angle. It should be nice and sharp and pointed. So can you see down there? It's quite pointy, and then on the left side that's quite pointy as well. If you've got small pleural effusions, then the first thing you often see is kind of reduction in that pointiness, so obliteration of those sharp angles. And we can't see anything obvious here in these lung fields. It all looks fairly uniform and normal. So this here is slightly different to the last one, and I don't know if you can see the difference. So if you look at the previous one, these ribs kind of go kind of veer downwards a little bit, but if you have a look at this one here, they're quite horizontal. So you remember that the ribs are like bucket handles, and if you as you breathe in or take a very big breath in, the ribs can become a little bit more horizontal. So anything that causes you to become hyperinflated can make your ribs look quite horizontal. So these ribs are quite horizontal, and actually there seems quite a lot of lung here compared to the previous one. So if you look at the previous one, we've got when you look at ribs, the first ribs here, you look at the posterior surface, the anterior surface, the first ribs here, the second rib, the third, the fourth, the fifth, sixth. Usually see about 6 to 7 ribs in a normal hemithorax. But if you have a look at this side, we've got 1, 2, 3, 4, 5, 6, 7, 8. We're maybe starting to see 9. So that's a sign that the lungs are hyperinflated. So this is somebody with a lot of air in their lungs. It could be COPD, it could be asthma, but this is what we might see, a hyperinflated lung field. So kind of big lungs, lots of ribs and horizontal ribs. This is another hyperinflated chest X-ray, and whereas the ribs aren't particularly horizontal here, what you see is the diaphragms are really low. And as a rule of thumb, women, you can usually see their breast tissue, and their breast tissue usually sits just below the hemidiaphragm. So the bottom of the breast will be just below the hemidiaphragm. And if you can see here, the breast, you can see the outline of the breast, the lower edge of the breast here, and it's quite a way above the hemidiaphragm there. So this is somebody who's very hyperinflated. And if you remember the previous chest X-ray, the lungs looked kind of greyish, but they look a lot blacker here, and it's because there's more air in, the more hyperinflated, and particularly down here it was really, really black, and you almost wonder if you might be missing lung markings here, if it might be a pneumothorax, but it's not. It's just hyperinflated lungs, and the heart, instead of looking kind of round and plump and sitting on the diaphragm, kind of floats above the diaphragm and is a little bit longer and thinner. So they're all markers of hyperinflation, and certainly we can see we'll see that in people with COPD. Right, so that's kind of your basic asthma COPD chest X-ray. Does anybody want to have a go at telling me what the obvious abnormality on here is? And if you need a clue, just kind of look at the right lung, compare it with the left lung, and see where the differences are. Anybody want to have a go? So this right lung is probably normal. It's quite hyperinflated again. So, you know, plenty of ribs, 1, 2, 3, 4, 5, 6, 7. Nice sharp angle down here at the right side. You see the breast shadow here, the diaphragm there. You can see the trachea, the right main bronchus, left main bronchus, and the vertebral column. So that looks okay. If you look on this side, the difference between the left and the right is you can see the left heart border, but that's normal. But on this left-hand side, you can see this opacity here that's not there. So this is a little bit of kind of dense, probably consolidation at that left base. So this is probably consolidation. It's probably a left lower lobe pneumonia. So if somebody's got crackles and a dual percussion note at that left base, you wouldn't be surprised to see this chest X-ray. So with the benefit of hindsight, you can see, can't you, that this whiteness here is not the same as the bottom of the right lung, and it's not the same as the top of the left lung either. So this is left-sided consolidation. You can still see the left heart border nice and clearly there. You can see the costophrenic angles there as well, so there's no effusion, but this is a left lower lobe consolidation. What about this one? So this is similar but different. Anybody want to have a go at which side is the abnormality on and what does it look like? So this time the abnormality is on the right side. So it's the difference between the upper zone and the lower zone is quite marked, and there's a straight line in between, isn't there? So you've got this whiteness at the bottom of the right lung that isn't. It's not the same as the top of the right lung, and it's definitely different to the bottom of the left lung as well. So we've got this right lower zone opacity. So opacity just means any whiteness that you see on a chest X-ray. It doesn't mean anything in particular. And you can still see ribs behind it. So it's probably not fluid density. So usually if you've got fluid, it's that it will obliterate everything that you can usually see there. So you can't really usually see anything behind it, but you can see the ribs. So I think this is some right-sided consolidation again. This line here is the right horizontal fissure. So that splits the right upper lobe from the right lower lobe. And so this line here means that whatever's going on is purely in the right lower lobe and not in the right upper lobe. Can you see the right heart border? Probably not, but you can see the right hemidiaphragm. So actually this is probably not right lower lobe, it's probably right middle lobe, because the right middle lobe of the lung sits next to the heart. And if you can't see a clear demarcation between the heart and the lung, it implies that the consolidation goes up to that bit of the heart. So this will probably be right middle lobe consolidation. Yeah, the right upper lobe is normal and there's no other abnormalities. What about this one here? Similar to the last one, isn't it? And again, you've got this opacity at the right base, the right lower zone, which isn't at the left base. Again, quite hyperinflated, lots of lungs there, and this straight line across. So this kind of clear demarcation between upper lobe and what's going on below there. And again, you can see the right hemidiaphragm nice and clearly, but you can't see the right heart border. So this is probably a right middle lobe consolidation again. So similar to the last one. What about this one? Anybody gonna speak up and tell me what's going on this chest X-ray? Which is the bit on the chest X-ray that doesn't look like the rest of the chest X-ray? Okay, so again, we've got some opacity and it's higher up this time, isn't it? And you can see that demarcation again, but the abnormality is not below the demarcation, it's above. So it's above the right horizontal fissure. This is right upper lobe. It's not very well demarcated at its kind of upper borders, so it's not looking like a tumor, but again, this is consolidation. It's right upper lobe consolidation, so a right upper lobe pneumonia there. Maybe a bit of something at the left base, but maybe that's just poor inspiration. So this is a right upper lobe consolidation. So it's this kind of not absolutely so dense that you can't see through it, but definite kind of obvious whiteness, which is consolidation. This is moving on to a different pathology. So what's going on in this chest X-ray? What does anybody want to tell me about this chest X-ray? Which side is the abnormality on for a starter?
The right base.
It is. So we've got this whiteness, haven't we, at the right base, and you can't see the right heart border, you can't see the right hemidiaphragm.
The right fissure.
And if you look at the shape of it, instead of being straight across like the previous ones, can you see that this is kind of slightly arched here? So it's kind of a little slightly rounded. It kind of goes down and then it goes up again, or up here as well. So this is what you typically see in a pleural effusion. So this would be a meniscus. So if you got any fluid against a surface, the fluid kind of clings to the side of the surface and will form a meniscus. So this shape here is quite typical of fluid there. So this would look like a pleural effusion. And can you remember the last few X-rays you've seen? You can see kind of ribs behind. You can just about see them maybe here, but generally this is so dense that you can't actually see much behind it. So this is fluid densities. This is really, really fluid. So this would be a right-sided pleural effusion. And there's no obvious masses or consolidation above that might explain that effusion, but that's a pleural effusion, and you'd have to think about what the cause of that might be and whether it needs further investigation. On the left side, can you see this angle is really nice and sharp? Again, it's nice and pointy. Bilateral effusion you get with heart failure or renal failure or liver failure, but there's not even the hint of an effusion on that left side. It looks like a unilateral right pleural effusion. And you'd expect that to be stony dull when you percuss it. You'd expect the vocal resonance to be absent. You'd expect not to hear any breath sounds or bronchial breathing or crackles or anything underneath there. What about this one here? Similar, but there's something extra. Can anyone spot what the extra bit is that wasn't there before? That might be iatrogenic.
Is the heart enlarged?
It is quite a large heart, you're right. Yeah. And we've got this, can you see this meniscus again? There's this dense opacity at the right base with the meniscus that looks like pleural effusion. So again, probably a right pleural effusion, and the left side looks okay. No masses or anything like that to explain why there might be an effusion. What's there that somebody medical has inserted into this patient? Can you see anything abnormal apart from that effusion?
There's a catheter, right, going on the right heart?
Absolutely, yeah. So there's this line here that's kind of going from who knows where, and it goes probably, I think this is probably subclavian line. So this is perhaps somebody who's very poorly that we've put a subclavian line in to give fluids or to monitor or to give antibiotics, or perhaps we've put this in and then it's misplaced and we're pouring fluid into the right hemithorax. That's always a consideration. If this has come on very, very quickly after we've put this in, then maybe it's misplaced and it's actually dumping its contents into the right hemithorax, which would be not a good thing to happen. I think if it was hemothorax, you'd probably expect it on the same side as the lines going in, but it could be. It's definitely a right pleural effusion. It's either somebody who's very poorly and needing monitoring or large IV access, or this might be the culprit. What about this chest X-ray? Anybody see anything there?
Is it a pneumothorax?
So I know why you're saying that, because those lungs look really, really black. So already you're kind of getting your eye in, aren't you, and saying, you know, what's normal, what's acceptable, what's abnormal. So it could be a pneumothorax, but if it was a pneumothorax, you'd expect one lung to look quite black and the other to look not so black. So were you thinking it might be a pneumothorax on the left side?
Yeah. Like on my left,
Yeah, and it is really black. But if you look at the right lung, then that's really black as well. So I think if this person had bilateral pneumothoraces that were so large, they probably wouldn't be sitting up for a chest X-ray. They'd probably be dead. So I think the blackness is, you're quite right. There's more air than usual in the hemithorax, but rather than being in the pleural space, that air is in the lungs. So I think they're really hyperinflated lungs, and the diaphragms are quite low again, aren't they? You can see. And lots of ribs. It's actually it's so black it's difficult to count the ribs. But on this left side you can see an opacity that's not on the right side, can't you? So we've got a nice sharp angle here, but we've got this opacity at the left base, and I think this is probably looks like a meniscus there with maybe a bit of consolidation above it. So it's quite dense lower down, a bit less dense higher up. So maybe a bit of consolidation and effusion, maybe a pneumonia with a parapneumonic effusion or an empyema there. But yeah, you're right. The lungs are very hyperinflated. They really are. They look very black. What about this one here?
Effusion again, right?
Yeah, so similar to the previous one, but a bit less startling because the lungs are, I mean, they're still black, but they're not enormous either. But again, we've got this meniscus here, this dense opacity at the left base. So this is a nice left-sided effusion, and probably the right side is okay. It's difficult to be sure. I don't know if we even get the angle properly on that chest X-ray. But yeah, this is a left-sided effusion there. Right. What about this one? What's not right about this chest X-ray? Where's the abnormality and what is it?
That's a pneumothorax.
It absolutely is. And why do you say that's a pneumothorax?
On the right, there's no lung markings, right? It's much blacker. And,
So a bit-
there's
Sorry, go on.
yeah, no lung markings, right? And you can see
Yeah.
more or less a line.
Exactly. So if you look at the left lung and the right lung, it's clearly different. This is really black, isn't it? A bit like the one two goes ago. And can you see this here? Anybody know what that is there? What that funny kind of bumpiness is? So in a pneumothorax, you get deflation of the lung and you get air in the pleural space. And so what we're seeing here is air in the pleural space, and there are no lung markings there whatsoever. And this is actually the punctured lung. It's the collapsed lung. So this is the lung that's shrunk down. And some people would look at that and go, oh, there's a tumour, but actually it's not. It's just the shape of the lung. So if you puncture the lung, if the lung deflates, it'll just shrink down and it can look like this. And when we're talking about lung markings, I think this is a good chest X-ray to kind of explain what lung markings are. So you see this blackness here and think, oh, that's a bit strange. Compare it with this side. Can you see all these little white lines here? And it's quite grey all the way out, isn't it? So these lines are the blood vessels there. And it's grey all the way to the very edge. So these are lung markings. And this, you can see there are no lung markings. So this is a large right pneumothorax. That will probably need a chest drain, I would imagine. And when we're looking at pneumothoraces, we talk about tension pneumothorax. And if your pneumothorax is big enough and there's still air leaking into the pleural space, eventually what will happen is the air starts to push the mediastinum and the heart over into the other hemithorax. And the way we can look for a tension pneumothorax with mediastinal shift is have a look at the tracheal position. So clinically we'd be examining for tracheal position, and if the trachea had been pushed to that left side, clinically we'd be very worried about a tension pneumothorax and probably want to decompress it before we did a chest X-ray. But if the trachea is central, you do a chest X-ray first, and the trachea is central. So these the little kind of middly bits there are the spinous processes, and they're in the middle of the vertebrae at the back. And can you see this kind of like tube down here? It looks black in the middle and white outside. This is your trachea. So this is right in the middle there. So you can see that the trachea appears to be central. It's equidistant from the clavicles, and although this person's got a large pneumothorax, it doesn't appear to be tensioning, which is good. What about this one? This is similar to the last one, but reversed, maybe, I suppose. So this is black, this is white. So is the white abnormal? Is the black abnormal? So the white bit, you can see lung markings there, can't you? The black bit, you really can't see any lung markings. So this looks again like a pneumothorax on the left side this time, and then this time this is the lung, which is kind of made a very strange shape. But this is the collapsed lung, and then this is air in the pleural space. And again, the trachea looks nice and central. So not a tension, but a large pneumothorax on the left side. Again, probably would need a chest drain. What about this one? What do we think about this one?
That one is tension, right?
Yeah, it is. So you've got this left lung is white, the right lung is black. You can't see any lung markings on the right side, but you can on the left side. And actually this looks really dense here, doesn't it? And can you see the trachea is central, but this mediastinum is shifted right over to that side. So instead of the heart kind of coming straight down here, it's been pushed over this side. You can see the right heart border, which has moved right over to the midline there. So this is because the amount of air in that right hemithorax is exerting pressure on the mediastinum and pushing the heart right over to the left side. And that's probably why that left lung looks quite white, because it's quite compressed. So this is a person that's in an awful lot of trouble. This is a person that you'd need to attend to very, very quickly, because if this continues, then eventually the heart will shift all the way over. There won't be any left lung capacity. The heart will come under pressure, and so that this patient needs decompressing with you see this on Casualty, don't you, on the television, where they put a Venflon between a couple of the ribs and there's a hiss and the patient perks up and then you can put a chest drain in afterwards. But you're quite right, that's a tension pneumothorax, which is a medical emergency. What about this one? Kind of a bit similar to pleural effusions, but slightly different. Can you kind of pick out the difference? So this is something at the left base here. And it's very dense, isn't it? So it's very dense, not like the consolidation. So maybe it's fluid, but can you see that we've not got a meniscus? So this is a dead straight line across here, isn't it? So instead of kind of curling up there, and this is what you see if you've got fluid and air in the hemithorax. So it's a hydropneumothorax. So hydro is water, pneumo is air, thorax is chest. So if you've got a pneumothorax and a pleural effusion, then you get this white, this dead straight line with no meniscus there. So this is a left-sided hydropneumothorax. And again, it's somebody who's very hyperinflated. There's a lot of, I suppose it just illustrates that there's a lot of comorbidity in COPD, isn't there? And I suppose the reason that we do a chest x-ray in somebody that comes into hospital with a COPD exacerbation, it's not to confirm COPD, it's just to exclude other things that people with COPD do get because of their risks, because of their risk factors and their comorbidity. So this dead straight line that's very dense underneath, this is a left-sided hydropneumothorax. And that could be caused by trauma, it could be iatrogenic after a procedure, it could be spontaneous, but that person would perhaps need an ultrasound and maybe a chest drain. What about this one here? Coming to the end now. I think we've got 3 more after this, but this was a slight curiosity, and it kind of comes back to the what's on this chest x-ray that's not present in nature, and can we see anything there?
Definitely a pacemaker.
Yeah, so you can see these wires here, can't you? There's this wire there and then that wire there. It's probably left ventricle, right ventricle. And these wires come together here, and that's a battery. So this looks like it's a pacemaker. So somebody's had a pacemaker put in, and what's happened, I think, as a result of the pacemaker? Can anyone pick that out? What's wrong in the lungs? Can you see anything in the left lung? Anything look wrong with the left lung? Can you see this here? It's kind of roundness. So what do you think that might be? Can you see any lung markings on that left side? Especially if you look up here, you can't really see any lung markings, none down here either. So could this be a pneumothorax? I mean, the lung markings aren't brilliant on this side, but if you look closely, maybe it does look a bit different. I think what's happened is this person's had a pacemaker put in, and because she goes subclavian, somebody's probably pranged the lung and the lungs collapse and they've got a pneumothorax, and I think that is the lung, that's the collapsed lung there. So I think this is an iatrogenic pneumothorax, and it's quite a large pneumothorax as well. What about this one? Moving away from pneumothoraces and consolidation, what can we see there? So look at both lungs and just try and work out what the difference is. There's something in one lung that isn't present in the other lung. Anybody see it?
A little nodule, right?
Yeah, so there's this right upper lobe mass, isn't there? This round white thing there, and that's not here on that side. And it doesn't look like it's an ECG sticker or anything external. It's kind of relatively well demarcated, quite dense. I'd be worried that was a cancer. I suppose at the outside it could be maybe a localized area of consolidation, but it's very round, it's quite dense, so I think this is probably a right upper lobe tumour, What else should we look at if we see tumours? I suppose, is there any pleural effusion? I think probably not. No, if you got enlarged lymph nodes, you might see some bulkiness here at the hilum. There's nothing on the left-hand side. The bones look okay, so there's nothing that looks like rib metastases. So this looks like it's probably a right upper lobe tumour, and you proceed to a CT scan to investigate that. What about this one? What do we think this might be? Or what can you see there? What's the abnormality in the lung field or fields? Is it unilateral or bilateral, this abnormality?
Bilateral.
Yeah. There's not a lot of normal lung there, so you can see the heart, but then it's kind of a bit whitish down here and a bit kind of patchy, not kind of dense and confluent, but kind of patchy, fluffy. Almost all of the right lung. It just spares the right apex there, and it spares a bit more of the left apex there. Quite a big heart, really. So this could be bacterial pneumonia, but I would expect somebody with this degree of bacterial pneumonia bilaterally to be really poorly, and they don't even seem to be on any oxygen. And we can't see any endotracheal tube in the trachea, so probably less likely to be bacterial pneumonia. Could be interstitial lung disease, I suppose. It could be, and it probably was. I think this was COVID pneumonia. So this is what COVID pneumonia looked like when we used to see a lot of, proper rip-roaring COVID pneumonia. This is the kind of bilateral, widespread, fluffy, patchy consolidation. Pulmonary edema can look like that as well. Pulmonary edema is said to show bat's winging, so it usually spares the peripheries and kind of occupies a triangle in the middle of the lungs, not the middle lobes, but the middle of the lungs there. So this was probably COVID pneumonitis, and we probably got very used to seeing that back in early 2020, and we've probably not seen much of it really since 2021, have we? And then this is the last one, which is similar to the previous one, but anybody spot any slight subtle differences or anything that we don't usually see on a chest X-ray?
There's a tube as well, right? There's a tube in there somewhere.
So there, there's a line here. This is a right internal jugular line, I think. So this is somebody who's got right internal jugular line, either for giving fluids or drugs or for monitoring. So maybe somebody who's quite poorly here. And again, you can see this bilateral fluffy consolidation, can't you? This opacity. And do you remember last time I said pulmonary edema can look like bat's wings and spares the periphery? So can you see that this shadowing doesn't go all the way out to the edges? It stops a little bit before, and it's kind of like almost like a triangle, like a butterfly wing or a bat's wing, presumably here. You can almost see that, can't you? Here, less like a bat's wing, but kind of spares the periphery. So that's probably pulmonary edema, and it might be that this person's got significant cardiac disease. They might be on ITU or coronary care, having pressure monitoring to guide treatment. So that this would do for pulmonary edema in somebody with a cardiac history. The heart's not that big, but it might be a bit rounder than usual. But yeah, so this is kind of your patchy, fluffy consolidation that spares the peripheries, that's in keeping with pulmonary edema. So that's all the X-rays, and I will unshare my screen, and then we can look at each other, can't we? Has anybody got any questions about X-rays? Any of the ones we've seen, or any X-rays that you might have seen, or any other questions you want to ask about X-rays and interpreting X-rays at all?
Hi, Justine. What I'll do is I'll stop recording. I think people feel a lot more confident when it's not recording to ask some questions.
Okay.